guys, welcome to our channel Anything Medicine. So today we are starting Papova family, which included 3 viruses: Papilloma, Polyoma, Vacuolating. How to remember which virus is included under this family? Remember it like this: Ba is Papilloma, Bo is Polyoma, and Va is Vacuolating. Okay? But today we'll emphasize on these 2 viruses, Papilloma and Polyoma, because the most important clinically and most commonly infect human. So, and also commonly being asked in high-yield exams. So, starting by Papilloma, it's actually okay. First of all Papova family are highly oncogenic due to owing the circular DNA. I told you in the first video of viruses that the only family which has the circular DNA is Papova family. All other DNA viruses own linear DNA, but this family have circular DNA. So if you want to draw the shape of the typical shape of this family, it will be icosahedral capsid, okay, with circular DNA and without envelope. If you want to more details, go for first video about DNA, general explanation about DNA viruses. So this shape is for all these viruses. Then Papilloma. It's actually a family which include 60 serotypes at least that discovered till now, and we are interested in some of them, not all, because just some of them most commonly infect human and commonly asked in high-yield exams. So serotype from 1 till 4. It actually makes skin warts and called verruca vulgaris. And this wart can be on face and can be on fingers and can be on foot, so we call it plantar. Also the one in face, they call it common. And the one in fingers they call it, common, and the one in face they call it flat. Okay? So the face they call it flat and finger they call it common. Okay? Well, actually these can reverse by own. If there is good immunity, these words can reverse by own. Next is serotype 6 and 11. Well, these serotypes are very associated with genital warts, external genitalia. So there will be a lesion called condyloma acuminata on the penis or on the anus. But mostly it will be benign, as well as here also, benign. But if we compare it with serotype 16 and 18, mostly it will start as benign, but soon will progress to malignancy. So this malignancy very commonly occur in cervix of uterus. So 16 and 18 very associated with cervical malignancy, cervical cancer, and vaginal also cancer. It can be vulvar and anal neoplasia. Here mostly if infect anus there will be benign lesion, but here it can also infect anus but make malignant cancer. One more thing that I didn't mention, that this circular DNA allow this family to incorporate into the host DNA and make malignancy, unlike the others which are linear, not easily incorporate. Yes, so this feature promote the malignancy beside the others that I will tell you later, because this family, for example, own protein which inhibit the anti-apoptotic genes in the cells, allowing for more division. This is another feature, so I'll tell you later. So we finished serotype 16 and 18. Next is prophylaxis. So first of all, how we can get these viruses? Well, if we talk about the skin warts, it will be infected or spread through contact with contaminated substances or surface. But serotype 6 and 11 and 16 and 18 mostly we acquired through 6, through the sexual process. So if we want to make prophylaxis against these, we should have safe contact, yes? So 6 barrier or contact barrier. Then another thing for prophylaxis, there is now a vaccine against these four serotypes, 6 and 11 and 16 and 18. So these vaccines called Gladacil, which protect us against, as I said, yes, 6, 11, 16, 18. And we have Cervirax vaccine, which protect us just against 16 and 18. Now, treatment. How we can treat these lesions? Well, as I said, some of them will be regressed by its own if there is good immunity. But if not regressed, so we can remove it by surgery or by laser, or we can apply chemical substance such as podophyllin. The most popular chemical substance used against this is podophyllin. And for laryngeal carcinoma, which included here also, I didn't mention, laryngeal papilloma, it's benign. Rarely it's cancer, malignancy. Laryngeal papilloma mostly associated with 6 and 11, okay? And it's benign. And interferon gamma is very affected against this, is very effective. So for laryngeal papilloma, as treatment, we can apply gamma interferon. And also cidofovir in general, if we apply it, because it's antiviral, it have some effects, good effects. Now, pay attention here that the name of this lesion, which caused by 6 and 11 serotypes, is Condyloma acuminata. So this point can be confused by a dermatologist or any doctor. So we have to differentiate between Condyloma acuminata and Condyloma lata. It's caused by syphilis, yes? Condyloma lata caused by syphilis, and Condyloma acuminata caused by human papilloma virus. So, what is the difference? Well, lata is sessile. Sessile means immobile, and it's it grows as one part, but here is pedunculated. And this acuminata easily bleeded if you touch it. Easily bleeded. You may think it's easy to differentiate, but it's hard actually, because they grow on the same place, and if you look from far, if you look from far away, you will confuse really. You will think really you will confuse because they look like each other from far away. So, and this not easily bleeded, not easily bleeded. And this is rot, this is rough, this is smooth and moist. So you should pay attention for this. You should look from close space, moist also. So these are the differentiative criteria in between these two diseases. And one thing more, before we finish the papilloma, one of the most popular questions or points that are targeted by high-yield exams, that what are the mechanisms of the oncogenesis. I said, first of all, the supercoiled DNA. Then, actually, this virus produce protein E6 and E7. And actually, E6 bind to B53, which is a popular. This is the policeman gene. It's tumor suppression factor. So when E6, which is produced by this virus, bind to B53 and destroy it, there is no suppression for tumor. Okay, so then there be like there be predisposition for malignancy. Same E7 bind to retinoblastoma protein, retinoblastoma RB, which is also an anti-apoptotic tumor suppressor factor also. Tumor suppressor factor. So it's also destroy or suppress it, then it predisposes for cancer, malignancy. Then the cells start to proliferate more and more. So remember, these are very well targeted points and very commonly asked in many exams. Next, so we're done with papilloma. Next is polyoma, and polyoma have or comprise of 3 viruses, which is JC and BK and MCV. At least focus on JC because commonly asked in high-yield exams. So it actually causes BML, which is progressive multifocal leukodystrophy or leukoencephalopathy. So from the name you can expect what will happen. So we will analyze it later. This infection is associated with AIDS and immunosuppressive drugs, and blood malignancies. So AIDS, we know what is AIDS, yeah? CD4 count decrease. And when CD4 count decrease till less than 50 cells per millimeter squares, then the GC appear or reactivated. Then the lesion fastly occur. So what is the normal of CD4 count? CD4 count in our body, it's between the range of 500 and 1500. So when it's less than 50, it's already high possibility to occur. Then immunosuppressive drugs such as natalizumab, a patient who's treated with natalizumab and influximab. These are immunosuppressive drugs used for multiple sclerosis, used for cancer. So these patients, we should be aware about this virus. Then blood malignancies such as Hodgkin lymphoma, leukemias. All these conditions predispose or promote the JC virus and this BML disease. Then BML disease symptoms, how the patient from what patient complain. First of all, early complaints are clumsiness, sensory loss and hemiplegia. Patient tell you like I feel weakness on one side of my body. Like weakness, just start as weakness then progress, and that's why they call it progressive. Multifocal because the lesions are in different areas of the brain. And these lesions appear in MRI as non-enhancing lesion. Non-enhancing mean no clear border, plus to non-enhancing it appears also hyper intense plus hyper intense. So remember, it's very important. If they tell you in a question non-enhanced lesions plus very intense, hyper intense, and plus the CD4 count less than 50, and patient use some drugs or have HIV, history of HIV or something like this, you should think about GC virus. Or maybe they tell you the symptoms, or maybe like they can tell you anything of these, but not all. So you should remember all. Okay, then, like, what is the pathogenesis? Okay, when we acquire this virus since childhood, and the virus will spend the latency in any organ, mostly kidney and brain and lung, but it loves kidney. And when any of these conditions which I mentioned occur, the virus get reactivated, especially when the CD4 count get less than 50. And when the virus get reactivated, it loves to infect the brain, not to spend the latency there, but also. And when it infects the brain, it infects a cell, especially oligodendrocyte. And we know that this cell inside the central nervous system function by myelination. So when it infects this cell, it makes demyelination, and it makes disturbances for several tracts and several areas. And due to this area, patient will feel hemiplegia, patient will feel sensory loss, patient will feel changing of vision, personality changes. It's like a little later, ataxia, aphasia. All these symptoms are specific for this. Clumsiness, not specific, but like typical. So clumsiness, sensory loss, hemiparesis, vision change, personality change, ataxia, aphasia. So if we make a spinal puncture, lumbar puncture, and we examine the cerebrospinal fluid, we'll see basic myelin protein increased due to oligodendrocyte damage. Yes? And we may find also mild leukocytosis, but it's not specific. But the thing that we should remember about it, that it's fatal, so that's why it's very important, and as I told you, commonly asked in many high-yield exams. So it have fatal prognosis. Unfortunately, there is no treatment, there is no effective treatment. Next virus. Well, the next virus is BK virus, and this virus spin the same we acquired during childhood. Most of us, we have these two viruses or these two viruses at least, GC and BK. Most of us have it, but because we have good immunity, these viruses act. This virus will be just lie in latency inside our organs. Same, but this virus will be reactivated not just when like when CD4 count decrease, such in AIDS or drugs. Mostly it's associated with kidney transplant. It's associated with kidney transplant. So remember thing just from the previous videos that we talked about another virus that is associated also with kidney transplant, and it's make kidney transplant rejection, same as here. So which virus is it? It is cytomegalovirus. So how we can know about which virus is it the cause of kidney rejection after transplantation, if it's occurred? So BK virus causes the rejection within 4 to 6 weeks, while this cytomegalovirus causes it more than, like after more than 6 weeks. So this is the difference. Then what it causes also? It can cause acute cystitis and ureter stenosis. And if it causes ureter stenosis, it can cause hydronephrosis. So that's it, the most important about this virus. Going to the next, which is Merkel cell virus. It's actually associated with Merkel cell carcinoma, a rare type of cancer, but very aggressive. Really, it's very aggressive because it's undifferentiated and make early metastasis. So that's it about this family. It's very important family really, and hope you got the benefit.